Hi, welcome to this video lecture on peripartum fluid management. My name is Ashley Miller and I'm a consultant in intensive care medicine and anaesthesia and IV fluid lead for the Trust. The purpose of this talk is to update you on current guidance to prevent harm from fluid mismanagement in the peripartum period. And we're going to look at some of the physiological changes in pregnancy and then see how these affect fluid management. Our main focus is going to be on hyponatremia, but I'll also address concerns that some of you may have about dehydration and ketones. And finally, I'll outline what fluid management strategies we should actually be using. So pregnancy induces a number of changes that make mothers hold on to fluid. By term, plasma volume increases by around 30 to 50%. Heart rate, cardiac output and renal blood flow also increase. This is to supply the metabolic demands of the mother and baby and also gives a safety net for any blood loss during birth. The body does this by holding on to water and sodium, but water is retained in greater proportion. And the ability to excrete water is also impaired in the third trimester. Now, all these factors combine together so that plasma becomes more dilute and sodium levels drop by around 5 millimoles. So the normal range of sodium by term falls to around 130 to 140 millimoles per litre. And similarly, while the absolute number of red blood cells increase, the proportionally greater increase in the volume of plasma results in a lower hemoglobin concentration. Now, probably the main problem with fluid management in the peripartum period is hyponatremia. And hyponatremia in pregnancy is due to the effects of hormones that are produced in pregnancy, like antidiuretic hormone and relaxin. And in labour, oxytocin exacerbates this, as it's similar to ADH. Drinking excess water or getting IV fluids can also make this worse. Hyponatremia is therefore common in labour, and in the mother, severe hyponatremia can cause headaches, confusion, agitation, reduced conscious level and seizures, and it also affects the baby too. So it's a serious and dangerous problem that we should make every effort to avoid. So how do we do this? Well, there's a very low risk of hyponatremia if fluid balance is kept neutral, which of course means the same amount of fluid going in as comes out. It's when fluid balance goes over 1.5 litres positive that the risk of hyponatremia becomes very high. Oxytocin administration also increases the risk significantly, especially if mixed in large volumes. So, for this reason, it's extremely important to monitor fluid balance strictly in labour, and we should try to keep fluid balance less than 1 litre positive, certainly less than 1.5 litres. And there is rarely any need for IV fluids in labour. Now, as well as being careful about fluid balance, there are certain things which mean we need to monitor sodium levels as well. So when should we do this? Well, this would include any lady on an oxytocin infusion. So remember, I've already explained that oxytocin causes or worsens hyponatremia. Anyone who's on IV fluids, which should be a rare exception and not the rule. Anybody we know to be hyponatremic already with a sodium level of less than 130, and anyone with a fluid balance of greater than 1.5 litres positive. And this last one really shouldn't happen if you've been monitoring the fluid balance properly and taking steps not to let it get this positive. Now, there are some really good national guidelines which go over in detail how to manage sodium in labouring women. I'm not going to go over all this in great detail, but please do pause the presentation and read through these yourself. There's also a QR code on the slide here you can point your camera phone at, which will take you to this on the internet. I am, though, briefly going to go over what we should do if we find ourselves with a woman who has severe symptoms of hyponatremia. This means a lady who's confused, agitated, drowsy, or fitting. Now, as always, get senior help. A doctor should prescribe 200 ml of 2.7% sodium chloride over 30 minutes, which is absolutely fine to be given by a peripheral cannula, and then also 20 milligrams of IV furosemide. And the patient is going to need close monitoring in a high dependency area. They're going to need frequent sodium monitoring and very careful fluid balance. Okay, let's move on and think for a minute about dehydration and concerns any of you listening may have about this with not giving IV fluids. Now, we all know, don't we, that labour is a hard, long and sweaty process. Women may not feel like drinking, and they may even be vomiting. So you could potentially end up in a situation where women are losing more fluid than they're taking in. So how important is this? Well, if people become water deficient from not drinking enough, the best sign of this would be hyponatremia, a high sodium level. And we're generally most worried about low sodium levels in labour. So failure to take in enough water and sodium levels going up a bit, or losing water through sweating, shouldn't be much of a problem. And also, the best person to manage a patient's fluid balance is usually the patient. Any dehydration will stimulate thirst and the patient will drink. And there may be some examples where women are vomiting excessively and can't keep any fluid down. Options here would include antiemetic drugs and replacements of any fluid deficit. Gastric fluid contains sodium as well as water, so appropriate IV fluid here would be 0.9% sodium chloride or compound sodium lactate, so you're replacing like for like. So one of the few indications for IV fluids during labour would be excessive vomiting and an inability to keep any fluids down. What's most important is to monitor the fluid balance accurately, and if you have any doubts, check a sodium level. Ketonuria is another thing that people sometimes worry about, and ketones in labour are produced due to stress and low carbohydrate intake, and this is a normal feature of labour. Allowing women to have sugary drinks will limit ketosis, although it's not clear whether it's even a bad thing or not, as is discussed in a Cochrane review. And giving IV glucose will definitely do more harm than good by causing hyponatremia. So what should we actually do then with our fluid management? Well, even high-risk patients should be allowed to drink water or sugary drinks rather than have IV fluids. Patients, as I've said before, are usually much better at maintaining their own fluid balance than us trying to do it for them. Often the less we interfere, the better. Let labouring women be in control of what they're drinking, as long as you're keeping a close eye that it's not excessive. So you do need to monitor fluid balance carefully. So let women drink, but make sure they're not taking in too much. You need to monitor how much is going in and how much is coming out. And once a lady gets to 1 litre positive, they shouldn't be allowed to drink any more until they've passed enough urine to drop below, say, half a litre positive. There's no place for routine IV fluid. There must be one of the specific indications that we've talked about. For patients with epidurals, it's important that IV access is in place, but it's not an indication for IV fluids, as stated in NICE guidelines. If people need an oxytocin infusion, then this should be given in low volume, high concentration infusions, so any effects on sodium are minimized. And remember not to worry about ketones in non-diabetic patients. So, indications for IV fluids in labour, definitely not a routine. Yes, some ladies need oxytocin infusions as part of their management in labour. We've mentioned these already. I've mentioned patients who may be vomiting excessively. Another reason that would be unusual would be a need for an insulin sliding scale. But if this is absolutely necessary and the patient's already got hyponatremia, then please do get expert advice on whether a sliding scale is really necessary and about how this should be managed. A good strategy would be to use 10% rather than 5% glucose at half the rate to limit water administration. What about after cesarean section? The goal here is to stop IV fluids and establish oral intake as soon as possible. As before, we're aiming for a neutral fluid balance, and we want to keep sodium levels in the normal range for pregnancy of 130 to 140. Please note that 0.9% sodium chloride and compound sodium lactate are not maintenance fluids and should not be administered routinely post-operatively. Just give your patient a cup of tea or a glass of water if they're thirsty. If sodium levels are low, then get expert advice. But the answer with hyponatremia is nearly always to give no fluid at all until the sodium levels come up. If you want any more information on IV fluids, then you can watch other video lectures by me, and you can also read the Trust guideline on IV fluids. Just point your camera phone at these QR codes to be taken to them directly. So, in summary, hyponatremia is common in pregnancy and it can be dangerous. So follow guidelines on managing sodium levels. Be rigorous about monitoring fluid balance. And remember that there's no role for routine IV fluids. Goal is always oral fluid, not IV, at all stages of the peripartum period. So thanks very much for listening. Drop me an email or message me on Twitter if you've got any questions. Thank you.